Good evening, all. My name is Dr. Arunkumar, your mentor for Study MRCEM OSCE sessions. So this is a very interesting session, very important for the OSCE sessions. Usually, you will get definitely a question which is regarding informed consent and capacity assessment. So please go through the video in depth, if possible, multiple times. So coming to the topic for the day is informed consent and capacity assessment. So what we will do is we will enter the topic with a case, and then once that is done, then I'll try to explain to you like how it can be done. So we have a patient, Mr. Stewart, 33-year-old man. He fell off a ladder at home and dislocated his left shoulder anteriorly. The X-rays will be given down. He has no other injuries. You have examined Mr. Stewart, reviewed his chest X-ray of the shoulder, and you have been asked to obtain the consent from Mr. Stewart for reduction of his shoulder dislocation in the ED, resuscitation room, under sedation. So this is a question. And the pie diagram, which is revealing is two divisions. One is for communication, and other is for teaching. Now, so I have intentionally put this informed consent and assessing the mental capacity in two different sessions because as far as I am the learning phase is concerned, I think these are two different topics which will definitely will help you when you learn it individually. So that's why I put like two different cases for two different sessions. So just to get to know the basics, you will have at least a minute to read the whole question. You will have an X-ray which can be kept in your table near your patient, or probably will be hanged up outside the door. And there'll be a small pie chart which will be revealing where and how to concentrate on your case. So this is how it is going to be the session. So once you start to prepare for your OSCE session, you will understand the first two sentences are there for every session, immaterial of whatever the topic it is. You have to introduce yourself to the patient. You have to introduce yourself to the, if it is a teaching session, it could be involving the staff nurse or probably involving maybe the EMT technicians who are nearby the patient. And the most important thing is you have to confirm their identity, because usually it will be the chest X-ray or shoulder X-ray or the ECG or the ABG of the concerned patient. But we have to make sure that the concerned investigation or the concerned paper which is kept on the table is of the patients, because that has a mark to be considered by the examiner. So once that is done, now regarding this case, you are basically going to obtain a consent regarding a procedure which has to be done in your department. So it is very important to ask the patient what he knows about the procedure. Now, that can be basically a normal, probably a normal drug-related question, or maybe a procedure-related question, or it can be just a normal procedure which has to be done on a routine basis. But whatever being said, you have to definitely ask, or you have to be concerned about what the patient knows. And accordingly, you have to explain what the procedure is to the patient. Now, once that part is done, now you'll have to go into the core question. Are you aware? You have to ask such a question like, are you aware about what condition you are suffering from? Now that is indirectly explaining the diagnosis to the patient, number one. And then once that is done, the X-ray of the shoulder will be kept on the patient table, which you might have to show to the patient and explain in a brief way how a common man can actually get to know what is about the shoulder, what is actually the problem related to the shoulder. Now, once that is done, you have to say that now the patient is currently in a dilemma where he needs to be treated or not. So you have to explain on why the reduction of the joint is required in that place. So there will be a couple of questions which will be asked from the patient himself, but that will be most probably will be answerable type of questions. So once that is done, you roughly tell him, show some empathy, be very calm in the situation, explain the procedure, what has to be done, and make sure he doesn't have any discomfort while doing the procedure pre-procedure also. Now, he might be very, very sort of anxious. He might ask you like, what are the other alternative methods which can be used for reduction of the shoulder? So we should be very much prepared to answer his questions in a very simple way. Now, that is very important when the exam is concerned, because none of the examiners doesn't want you to use medical terminologies to a normal patient. So that's very important. So it is very important to explain the whole procedure to the patient in a very simple way and in a normal common man's terminologies. Once that is done, you can explain the risks of sedation and the risk of joint manipulation, and give a pause in between each stage of explanation. Make sure the patient is understanding whatever the information is being bombarded from you to him, and make sure you put this information in pockets so that too much of information is also not that great from your side. So give space, put a pause, give some very valid short points so that you explain to him very clearly, and he gets to know what you're going to do to him, right? So now, once you have explained the entire procedure, the sedations, what you're going to do to the patient, what he's suffering from, you ask the patient what he's thinking about the whole scenario. And thereby you answer all the patient's questions appropriately, show empathy, give space, ask further, is there any sort of other concerns for the patient? Give the time to think, avoid any form of forcing. Do not use medical languages. I meant medical terminologies, which is not understandable for the common man. So most probably when you go for the exam, you will definitely see patients, or probably they'll be asked to pretend as if they didn't understand what you're saying. So it would be advisable to use non-medical terminologies, very simple language, and you finally ask them, is there any other further questions? Now, once that is done, the entire session of informed consent is done. Then you ask the patient to sign the consent form. Now, what can appear is the patient himself actually can have a couple of other questions which you haven't explained, or probably the patient can ask you to repeat whatever you have said. So you might be well prepared for that also. So the presence of mind is very important during this session. As far as OSCE is concerned, any session you have to have presence of mind. But this station is basically a properly communication related station. So you need to be very slow, put a pause, make sure the patient is listening, make sure the patient is understanding whatever you are saying. So that's how you run this station. So this is about informed consent. Usually this informed consent is clubbed along with mental capacity assessment as well. So that is our second part of this session. So I'll be going through a small theory part before the mental capacity question. So we'll come to a question. Before that, we'll just brush through the theory parts. So what is this mental capacity? So the ability to make an informed decision that is task specific. So according to the Mental Capacity Act 2005, any person aged more than 16 is presumed to have mental capacity to make their own decisions about their patient care and treatment. So you will not be asked about all these definitions, but you'll be asked to assess the mental capacity. So coming to the question, like as far as OSCE exam is concerned, the assessment of mental capacity is a two-stage test. So we will come one by one in the depth. So first of all, you have to ask or you have to observe, is there any impairment or disturbance in the functioning of patient's mind or brain? Now, if so, is the impairment or the disturbance sufficient that the person is unable to make that particular decision? So these are the two questions which you have to be asked in the initial stages of assessment of mental capacity. So regarding the first part of the test, it is very important to check whether the patient is oriented to the time, place, and person. Now, that's the first part. Now, what are the possible causes? What you're looking for? Now, that could be a stroke or a CVA or a traumatic head injury, a mental illness, a dementia, maybe a learning disability, or the patient is in a confused state or drowsy or unconscious due to either illness or maybe because of its treatment also, or the patient might be having a substance abuse or substance misuse history, and patient is currently intoxicated with alcohol or any other drug usage. So that's about the first part. The second part is basically the application of the functional test to confirm the presence of mental capacity or the lack of it. Now, a small mnemonic has been used for this, which is like a URBI. So, understanding the information relevant to the decision, retaining the same information, balancing or weighing up their options, informing or communicating others of their decision. So, these are the four pathways, or these are the four fingers whereby we can actually deem the patient is lacking mental capacity or the patient is having a good mental capacity. So failure of any one or more of the elements means the whole test is failed and the individual will not satisfy the test for the mental capacity. So let's see a small chart which is explaining the whole conversation which we just had, the entire discussion which we just had. So we start with, are there any grounds to question the patient's mental capacity? If so, you identify and clarify the decision in question. Now, once that is done, can the decision be put off until the patient regains capacity? If yes, defer the decision until the patient regains capacity. If not, then you go to the stage one, in which we have discussed, as we have discussed earlier, is there an impairment or a disturbance in functioning of the brain or mind? If no, mental capacity is presumed to be present. Now, if yes, you pass on to the next stage where you give that four-finger question, which is understanding the information, the retaining the information, weighing up the information, and informing or communicating the same to others. Now, if the patient fails that also, then you can very well say the patient is lacking mental capacity. So this is a very simple flow chart which is explaining the whole procedures. So now you know the theory, you know what are the questions to be asked, how do you prepare yourself to be asking the questions, what are the type of questions which you should be asked, what are the two stages of asking for mental capacity, and then that being told, you will straight away go into the question. So before that, all the possible means of communication should be used to assist the patient to make a decision. That's very important because in the exam, we have just 7 or 7.5 minutes, probably 7 minutes for the session. And what the examiner will be looking forward is, are you coming to a conclusion or are you bringing the patient all the possible ways of communication which will assist the patient to come to a decision making. So it is upon to how you act on that sort of 7 minutes which is given to you. Now, usually in the case scenario, there'll be only one patient, or probably there can be a patient along with a relative, or even an advocate or even a carer can be there in the same room. So they can also actually help you out in the same case. Now, if after finding that patient is actually lacking mental capacity, it should be in the best possible interest of the patient, and it should be the least restrictive. So that should be your conclusion of the station, right? So we'll go to the question straight. Mr. Ben, a 74-year-old man who presented with red swollen limb, you have diagnosed cellulitis, admitted him for IV antibiotics. You felt that Mr. Ben lives by himself and he would not be able to cope. The nurse now informs you that Mr. Ben no longer wants to wait in the hospital, wants to go home. She feels that Mr. Ben appears confused. Assess Mr. Ben and make an appropriate management plan. You have ambulatory care at the hospital. So that's your question. Looking onto the pie chart, the limbs, what has to be showcased will be your examination skills, your communication skill, and clinical reasoning. So again, whatever we just told, we just incorporate everything into this answer. As the last session, what I have told, please introduce yourself to the patient, just like that. I will just explain to you how do you introduce yourself. Hello, good morning. I'm Dr. Arunkumar. I'm the ED registrar of this hospital. I have come here to ask certain questions and certain information from your side regarding the illness. Would that be okay for you? So that should be the way how the tone, the usage of words, the showing of empathy, the giving the space, everything should be like that. And you explain reasons for discussions, because a lot of these patients, especially elderly patients, they may not be in the presence of mind to understand why they have actually come to the hospital or why they want to talk to you. So it is always good that you actually have a very friendly chat with them initially. Introduce yourself, get to know them, like in the span of, in this exam, probably like you can take like 30 seconds to 45 seconds for that question or probably that part. And once that is done, you straight away come to your core topic. So you have to assess the patient's orientation to the time, place, and person. Confirm that the patient is not confused. Clarify patient's understanding of his illness, because it's very important to know that, okay, the patient know about his illness, or probably at least know that he is sick or he is ill. And there is definitely an indication for him to come to the hospital. And you explain reasons, what are the possible benefits if he stay in the hospital, what he is going to get. And if he is still asking you that he wants to go back home, you explain the concerns. If the patient go home, there'll be a lot of risk involved, there'll be a lot of time frame delay, and probably the disease condition actually can go bad also. So you have to probably quote on these terms to the patient. Now again, you ask his concerns and reasons for his decision. It's very important to know that rather asking about his concerns, it is very important to know that why he is concerned of, why he wants to go back home. Probably he might tell you reasons like his grandchild is the only person there at home, or probably his pets are there. Probably there is nobody else to take care of that. So it's very important to know why he wants to go home. And if there is genuinely there is a reason for him to go back home, you definitely should offer help also on how to tackle the situation. So these are the small points which actually you go out of the box to help the patient, which will fetch a lot of marks from the MRCEM exam point of view. And you check patient's understanding of the situation. Now, once you have done the first part, now we are coming straight away to that 4-finger questions. That is understanding the situation. The patient is able to retain relevant information. Patient is able to balance the risks and benefits. Patient is having the ability to inform or express his wishes. Once that is done, you'll be able to confirm whether he has a mental capacity or not. Now, once that is done, if there are bystanders along with the patient, you should be able to inquire whether the patient wants to discuss his decision with his family. Now, after doing that, if still he wants to go back home, definitely you'll have to respect the patient decision to go home. And still you may have to suggest him an alternative plan on how it can be worked out. and explain the deterioration and the risk involved if he goes back home. And if still he wants to go back home, provide him a safety net advice of the clinical condition. And after that, you agree, you sign the papers, and then discharge him from the emergency. Now, this is how you have to explain him regarding the mental capacity assessment to the patient. So, as I said earlier, usually it will be a very clubbed station. Uh, it will be like the informed consent as well as a mental capacity assessment will be or can be in a single station. So you might have to integrate everything in your that 7-minute point based station. So it is very important to have a thorough knowledge about the station, use your presence of mind, and definitely give space to the patient. Obviously, you have to use very simple words. You cannot complicate things that will actually degrade your marks. And so this is how you have to systematically tackle the mental capacity assessment and informed consent station. Thank you all for your patient listening. Hello all, good evening. My name is Dr. Arunkumar K. I am the MRCEM mentor at StudyMEDIC for your MRCEM OSCE exams. Today we are going to discuss about a very important topic regarding the MRCEM OSCE exam is concerned. It's a very important topic because you will have definitely at least 2 stations of resuscitation. Now, this is a very important station because this can be asked in various forms, either in the form of a communication station. Yes, communication will be involved, but more than the communication, it will be asked in the form of a team leadership, how you want to perform the resuscitation, how your clinical skills are, how your clinical reasoning is. So there are a lot of limbs on how a resuscitation question can be asked. So having said that, we'll straight away jump to the station. Now, I'll just explain to you before running the case. We'll have actually 2 cases. I have programmed 2 cases for this. One is a shockable rhythm and other is a non-shockable rhythm. So before going to that core question-based OSCE discussion, I just wanted to run through a small scenario on how you want to prepare yourself when you enter the station. So as every exam, as what I have always explained, you will have 1 minute to read about the whole question and what the pie chart is concerned of. And the most important thing is you should know what is there in the pie chart and what are the percentage of marks involved in each separated pie diagram. So I'll just explain to you, like once you have read the question, now you're entering the zone, that is you're entering the classroom. What are you going to do in that area? So it's very important to prepare yourself in the scenario room. So the most important preparation will be, so we have certain things which has to be prepared. The most important thing is the people. People means what are or which are all the staffs involved in the resuscitation room. So what you have to know is, you have to know what are the skills of the staffs present and what other skilled staff will be required if those staffs are not present in a scenario room. So before that, what you have to do is you have to introduce yourself, know who all are the teammates, ask them what is the level of competence, what they are confident in, and then you assign certain tasks which they have to perform to the best of their ability. And again, you have to think ahead on what all other staffs are required from other departments. For example, you might need a senior ED staff or probably a person from critical care or from pediatric or pediatric intensive care, or even if it is a obstetric cardiac arrest, you need people from obstetricians and neonatologists also. So it is very important to know that this is a team event, and it is very important to know that you have to ask for help at the earliest, because earlier the help asked, earlier it is for the management of the patient, and the best prognosis achieved with almost like a team management. So once you have done with the people, the second thing what you have to check is you have to check your equipments. That is monitors, the oxygen probes, the NIBPs, the capnographies, and the defibrillators. And you have to assign a certain person who's competent enough to use the defibrillator, because not everybody will be confident enough to use a defibrillator. So you'll have to definitely ask that question, are you confident enough to use the defibrillators? The third thing is equipments, in which the most important thing is personal protective equipment. Very important to clean our hands and wear the gloves and aprons, and ask the staff or the team to do the same. The next thing is airway, oxygen. It's very important to check the suction apparatus. You have to know what all airway adjuncts and equipments for intubation is ready or not. Coming to breathing, it is very important to know what are the possible ambu bags available, and is it a self-inflating ambu bag with a proper reservoir bag, which has to be connected to the oxygen port. So once that is done, you go to the circulation part, where you have to see the defibrillators, the pads and connections, how many IV access points are there, any intraosseous access points, usage of portable ultrasound. Now coming to disability part, you have to ask for temperature probe. In case of a traumatic resuscitation, you might have to address about the warm fluids in case of hypothermic patients. And drugs as such, probably you have to ask about the resuscitation drugs and the rapid sequence intubation drugs, and specific drugs regarding the situation. For example, if you're dealing with a hypovolemic shock, probably you might need a PRBC or blood transfusion, or even if it is a traumatic pneumothorax, you might need a chest drain kit also. Now, so that's about the preparation part of the scenario. Now coming to the scenario as such, how do you run? So you have to be very careful about how you want to assign tasks to every person in your team. So first of all, assessment of the patient and the initial management has to be done with a proper systematic review, just like how you go for the ABCD format. And once that is done, you have to clearly know where the patient is in the resuscitation protocol. So invariably, you have to be well learned about the protocols and algorithms, and you have to have the knowledge what all investigations are probably the protocol based investigations which has to be done for the patient on the concerned time. And then above everything, the communication skill has to be upfront, and your decision making should be very precise and should be informed to the team very clearly in the best possible way. And it's very important to gather the information from the paramedics and the other nursing staff, the family members, any sort of letters or any sort of chits which has been given from the GPs or from the referral hospitals when you take history. And it is very important to show empathy and to the family members, and it is very important to assign one staff to the family member for good practice. And it is very important to have a very positive body language. The empathy should be there, and you have to probably repeatedly ask them, are they comfortable? Are they okay? Is there any sort of help required for them to be comfortable? Now, again, we all know resuscitation is a big time chaotic environment, and it is very important that you should be in control of the whole situation. And as far as the exam is concerned, you will be the team leader and you will take an overview of the entire situation, and you have to provide clear and confident instructions. And if you are unsure about how the management plan is going, you should not hesitate to discuss with the team. Probably they may give an opinion which should be considered. if the case is not going in the right direction. And you have to ensure overall care, because the CPR training person or probably the CPR doing person may not be doing the right way. So you should be able to point it out and ask them to convey the activity in the right direction. So appropriate chest compressions, the ratio of ventilation compressions, safe defibrillation techniques, and sharps and infection control precaution has to be told while involving the scenario. Now the decision making, as I've told earlier, the critical decision making has to be told to the team in the right way at the right time. So if you are not able to track down on why the patient is not yet achieving resuscitation or ROEC, you should not hesitate to ask your team members for the advice or help. Or in case if you're not remembering as I've just told an example here, the fourth reversible T is not, you will not able to remember it. So it is okay to ask your team members. So thereby you are having a very open conversation, and that will fetch you more marks in the exam also. Again, once you have done with the resuscitation, and if there is successful return of spontaneous circulation, you should not forget to initiate the post-cardiac arrest care and hand over to the critical care colleagues. And if there is a reversible factor, for in case if there is a patient is having a STEMI or ST elevation MI, you should have a word with the cath lab and the doctor there, and you should be able to communicate to the family about the ongoing care and the further management. Last but not the least, it is your team. You are the team leader. It is very important to thank the team, and it is very important to be together with the team in the sort of critical junctions. And you always be with the team once the resuscitation is done. You give them the space to address the problems which they encountered during the resuscitations, clear the doubts, give them the space to express their problems, listen to what their issues are. So that is also a part of your team leadership skill. Again, keep an open mind. Very important to know about the relevant algorithms. A calm and logical and a presence of mind is very important during the resuscitation. Go by a very systematic approach by the ABCD assessment. Reversible causes has to be addressed, and there should be a proper logical thought behind your actions, clarity of ideas, and clear communications, thereby achieving good leadership and successful outcomes. So that is a small theory behind the resuscitation questions. So coming straight to the question, a 60-year-old man on his way to the ED following an out-of-hospital cardiac arrest. He was at a meeting when he suddenly felt clammy and short of breath. Then he collapsed. The bystander CPR was started immediately, and the paramedics arrived. He was in BF, treated with 2 shocks with return of spontaneous circulation. But again, he lost output again. He's intubated but not cannulated. He will be arriving to the ED in 2 minutes. There is a student nurse and a competent junior doctor with you. So that is your question. Your pie chart is revealing 3 things. 1, it is team leadership. 2nd, communication. 3rd, the resuscitation. Out of which resuscitation has the most number of marks which has to be put for the current station. Now, they have connected to the monitors. So the initial patient observations will be provided to the staff nurse when you are asking them. Airway, the intertracheal tube is secured. Breathing wise, the respiratory rate is like around 12. Clear lung fields. Saturation is 100%. Circulation is no cardiac output. Rhythm is BF. CRT is 5 seconds. GCS is 3. Temperature is 35.5. Blood sugar is 9.3. And you will be shown a ECG. Your rhythm is here already. So it is very important to identify the rhythm and start the management. Again, the same thing. We'll run the scenario just like how we have discussed earlier. Preparation of the scene. People. That is basically you ask what the patient's, so the staff's skills are. What all you have to have an idea what other skill staff is required. Introduce yourself to the team. So this is basically, this can be run like, I'll just put a scenario. I'll just run this case. So hi all, good morning. My name is Dr. Arunkumar. I'm the ED registrar here. May I know your name and designation and the competency, please? Thank you. May I know the second staff's name and competency, please? Thank you all. Then once that is done, I should be assigning specific task. So, hi, staff A, would you be comfortable enough to take care of the airway? Thank you. Hi, staff B, would you be confident and comfortable enough to take care of the IV cannulation? Thank you. So once that is done, you have to close the question by thanking them. So it's very important to use such words. So once you have assigned your team, so this is the place, this slide is basically teaching you how you want to assign, you have to prepare in your scenario room. Once that is done, as we have discussed earlier, you basically have to check all the monitors. You check your monitors, means the oxygen probes, the NIBP, the capnography and defibrillators. Again, the equipments wise, you have to check your personal protective equipments, and you have to definitely clean your hands, wear the gloves and aprons. Airway wise, oxygen suctions, airway trolleys. Breathing wise, self-inflating ambu bag with a reservoir connected to the oxygen. Once that is done, circulation wise, basically defibrillators, pads and connections. IV access, intraosseous access. Disability wise, check the temperature probes. Warm fluids in case of hypothermic patients. Drugs, which is involving the resuscitation drugs, the rapid sequence intubation drugs, and specific drugs and equipment for in case the patient has a pneumothorax, we need to arrange sustain kit. If the patient is in hypovolemic shock, probably we'll have to arrange the blood for transfusion. Again, just running the scenario, introduce yourself to the team, confirm the competencies, take adequate infection control precautions like protection PPE involvement, ask to prepare the resuscitation bay, make a plan and delegates the roles to the nurse and junior doctor. Once that is done, ask the nurse to check the monitors, resuscitation trolleys, E to CO2 monitors and drugs. On arrival, you confirm the patient is in cardiac arrest. Ask the team to commence the chest compression. Take a brief history from the paramedics. Take over the airway and check the tube placement. And once that is done, check the rhythm and confirm the ventricular fibrillation and defibrillate the patient. So once that is done, you continue the chest compression while charging the defibrillator. Very important to ensure safe defibrillation techniques. Immediately, chest compression has to be started without checking the pulse. Achieve the vascular access. Consider the reversible factors of 4H and 4Ts. Very important to following the algorithm correctly, and important to know the drug dosage of amiodarone and adrenaline, and very important to rotate the team members to avoid excessive fatigueness while doing CPR. Very important to monitor the rhythm so that you identify the change in rhythm, recognize the ROC or return of spontaneous circulation. Once that is done, you initiate post-ROC care and need for therapeutic hypothermic management. Again, ask for a 12-lead ECG. Now, you will recognize that patient is having a STEMI. You inform the cath lab, you call the cardiologist and intensivist, and hand over the patient to the specialist. And make sure the patient reaches the cath lab on time. Very important to communicate the management, what has been done to the patient and what is going to be done for the patient to the family members. Show empathy. Now, Again, thank the team always. Now, this is one of the limb which has to be done. Now, you could end up in the case scenario where you may not be able to achieve ROC also. Now, that is also a possibility in which you don't have to worry, because uh, more importantly, you achieving ROC is not what is important. How you are running the situation, how you are running the station, how confident you are, how you are able to execute your skills in the right way. That is what has been monitored, and that is what has been fetching your marks. So you don't have to worry about the outcomes. So there could be a station where probably you may not be able to achieve ROC, and the examiners is probably the patient bystanders might be having a very bad time, or probably they might be having a very rough time with you while encountering the ROC. So there your team leadership and communication might be put into test, and it is very important to know that not your outcome is what is important, but how you run the scenario is what is important. Having said that, this is something which we have already discussed while explaining this theory. So we will go into the second case. There is a pre-alert about a 64-year-old patient brought to the ED in cardiac arrest after sudden collapse with no preceding symptoms. The patient has received appropriate compressions and ventilations with 3 doses of adrenaline, but is still without a cardiac output. No shock has been delivered. A past history of diabetes mellitus, atrial fibrillation, congestive heart failure, and chronic renal failure. And he lives at home with his wife. You have a trained nurse, a new doctor with you. The patient will arrive in 1 minute. Now, the initial observations which will be given to you by the staff nurse: airway, endotracheal tube is in place, breathing wise respiratory rate is 0, no respiratory effort. Circulation wise, no palpable pulse, your monitors are connected, and your rhythm is this. I'll just give a small pause to read about the rhythm. You can actually see a good organized rhythm in the monitor, but unfortunately there is no palpable pulse. So what you are seeing is a pulseless electrical activity. Moving on to the disabilities, the patient is unresponsive. Exposure, the temperature is 37 degrees. Blood gas analysis has been done for the patient. The pH is 6.93, PCO of 11.2, PO2 is 24.3. Sodium is 138, potassium is 7.8. Base excess is -19, bicarb is 13, lactate is 9.4. Altogether, the patient is in metabolic acidosis with a lactic acidosis, and the patient is in PEA. Right. What are you going to do in this scenario? Whatever the scenario it is, you start with introduction of the self to the team. You check team members' competencies. You brief the team on the expected patient, because the question will be patient is about to arrive in ambulance onto your AD. So you have to brief the team's clinical scenario to the to the team members, and you prepare the resuscitation bay. How we just discussed: the people, the monitors, the ABCD approach, and you give specific tasks to team members. Check and prepare the airway trolley. Check the resuscitation trolleys and drugs. Check the defibrillators, monitors, ETCO2 for monitor after intubation. Once that is done, you are preparing for the arrival. You ensure personal protective equipment for the team. You arrive when the patient is in arrival. You confirm the patient is in cardiac arrest. You ask the team to start CPR, attach the monitors, confirm the patient is in PEA, and you get a brief history about what has happened from either from the paramedics or from the family or from the bystanders, whoever has come with the patient. You reassess the airway, confirm the correct placement of endotracheal tube by auscultation and ETCO2 measurement. Once that is done, you gain the IV access, take blood for the urgent blood gas analysis. Now, this is a scenario where if you happen to have no blood test available, definitely you have to while achieving the IV access, you have to take blood for the blood gas analysis and appropriate blood test. You continue to do uninterrupted chest compressions, and you monitor the chest compression ventilation ratio. Ensure adrenaline delivery at the right time. Ensure good quality CPR. Reach the rhythm and pulse every 2 minutes. Go through the reversible cause, the various H's and T's, and you identify the patient's ABG has acidosis and hyperkalemia. Correct the hyperkalemia. Adjust the ventilation in view of the information, because the patient is having a metabolic acidosis with a respiratory alkalosis. So it is very important to adjust the ventilator settings accordingly. Then once you have corrected the hyperkalemia, you identify the presence of cardiac output. You identify the patient has returned to ROC. You re-evaluate the ABCD. You start post-resuscitation care. You contact the intensivist and hand over the case to intensivist adequately. Again, very important to talk to the patient's family members regarding the current situation, explain the bad prognosis, explain the possibility of prolonged ICU stay and hospital stay, show empathy, give them the space to reflect back on what they have gone through, allow time to be asked questions, and make sure you tell the answer in a very simple, straightforward, in a very short way. Do not bombard them with information which is hard to swallow or it's very hard to understand. Once that is done, return back to your team. You again thank your team for the help which has been done. Thank the skilled people who have arrived from other departments to your team to help you out in this chaotic scenario. And make sure everybody is safe, everybody is well explained, everybody has done their perfect job in the resuscitation. So this is how you do your resuscitation scenario. Now, the most important thing is this explains your way of how you deal a chaotic environment. So why resuscitation station is important? Because the resuscitation station is going to be the most sorted out station in the whole exam. You might have one station or probably two. It could be adult, or it could be pediatric, or it could be a traumatic resuscitation also. So it is very important to know all the points regarding the resuscitation. And all the best to you guys, and looking forward to more such videos for THM. Thank you all once again for your patient listening.